From Microbe TV, this is Infectious Disease Puscast, episode 62, recorded on August 30th, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. How are things with you this morning? We're recording in the morning, Daniel. People probably don't know, but that's the opposite of what we usually do.
Well, it's a little thrown, right? Because I was in Singapore and then I was in Taiwan and I got home late last night. And with all the time, change things, we moved it to this morning. Because what would it have been? It would have been like Wednesday night, which would have been like early for me Thursday morning. And I think I had like lectures to give or something. So, but I'm happy to be back, and I'm excited to go through the infectious disease literature.
I love it. Yeah, Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. Well, I am going to start us off with our viral section and remind everyone to listen to This Week in Virology. Actually, I was surprised how many people in Singapore and Taiwan are TWIV fans.
Oh,
sort
cool.
of nice to see that. But so we'll keep doing that. And if the Infectious Disease Puscast is your entree into the Twix universe, go to TWIV as well. But we will start off with the article, Clinician Specialty and HIV PrEP, Prescription Reversals and Abandonments, published in JAMA Internal Medicine. And we've spent a little time both here and Sara on her podcast, Febrile, discussing the importance of post-exposure prophylaxis, PEP, and pre-exposure prophylaxis, PrEP. And we even talked about the exciting idea of PIP, of PEP in pocket of PIP, which I want to co-opt for COVID-19 mean Paxlovid in pocket. So COVID PIP, what do you think about that, Sara? Is that going to catch on? No.
I don't know.
Okay. Not even going to humor me there. So here we read about the results of a cross-sectional study of patients who were 18 years or older that used pharmacy claims data from 2015 to 2019 on new insurer-approved PrEP prescriptions that were matched with clinician data from the U.S. National Plan and Provider Enumeration System. Data was analyzed from January to May 2022. So 2 important terms used in this study. So reversal, which is defined as a patient not picking up their insurer-approved initial PrEP prescription. I don't know if I use that much, but reversal. And abandonment, defined as a patient who reversed and still did not pick up their prescription within 365 days. So I guess that poor prescription has been abandoned there at the pharmacy for a year. I'm going to use this in conversations in the future. Hey, you remember that script I wrote for you? Did you, was there a reversal issue? Was it abandoned at the pharmacy? Maybe they'll sort of, by that, personification, or anthropomorphism of the prescriptions, somehow make them want to go and take care of that poor abandoned script. But of the 37,003 patients, 4,439, 12% were female, 88% were male, 77% were aged 25 to 54, a total of 24,604. So 67% received prescriptions from PCPs, 10% from ID docs, 24% from other specialty clinicians. The prevalence of reversals for patients of PCPs, ID specialists, and other specialty clinicians was 18%, 18%, and 25%. And for abandonments, 12%, and 20%, respectively. So it's sort of interesting. There was a headline on this, but I think I look at that and it's ID docs and PCPs do a little bit better, I guess, than other specialty docs. After adjusting for confounding, logistic regression models showed that compared with patients who were prescribed PrEP by a PCP, patients prescribed PrEP by an ID specialist had 10% lower odds of reversal, 12% lower odds of abandonment, while patients prescribed by other clinicians, right, 33% had higher odds of reversal, 54% higher odds of abandonment. So, as I sort of intimated, people are making like a big deal over the results here. And one is that the majority of PrEP is being done by PCPs, and I think that's true. Actually, critical. That's who really needs to be doing this, right? That's where we really have that contact. The second is the odds of patients filling a PrEP prescription better when it came from an ID specialist. Maybe I'm not so impressed there. I think that I am concerned that after all this effort, about 20% of those PrEP scripts just never get filled and are abandoned and left there at the pharmacy.
I pulled something from the Journal of the International AIDS Society, the association between adherence to antiretroviral therapy and viral suppression under dolutegravir-based regimens, an observational cohort study from Uganda. So authors here use longitudinal electronically measured adherence data and viral load test results to estimate this relationship between adherence to dolutegravir-based regimens and viral suppression in Uganda, like the title. 91% of patients in this site had switched from non-dolutegravir ART regimens to dolutegravir over this period of 2018 to 2022. Which allowed them to sort of look back at this adherence and suppression before and after the switch to dolutegravir-based regimens. And so under the non-dolutegravir regimens, 96% of patients or participants were virally suppressed when the adherence was 90% or higher in those 3 months before the viral load was checked. Suppression was 32% lower when adherence was between 0 to 49%. So that's like 54-ish percentage or proportion-wise that had viral suppression. For those on dolutegravir, when they looked at it after, there was no statistically significant difference in viral suppression among any of the 4 adherence levels. And so they reported it out as 90% adherence or greater, less than 50%, and then in the middle there they did 50 to 79 and then 80 to 89%. So over 95% of people who had less than 50% adherence were still virally suppressed. And so I snapshotted figure 1 here because I think this is just a nice illustration of the adherence level, which is on your x-axis, and the proportion of viral suppression. With the take home here being that there seems to be this huge degree of forgiveness with the missed doses with a dolutegravir based regimen. I guess I was a little surprised, like the less than 50%. I know there's been some of those studies. I think maybe you've brought them on, or maybe I did it. I don't remember, about like, even folks who were taking regimens and getting like 4-ish of the doses per week were still virally suppressed. So not that we want to advocate for this, but it just shows that there's probably a little bit of flexibility in keeping patients virally suppressed, even if there's not the best adherence. So I think it's pretty cool.
Yeah, it's surprising, right? You wouldn't
Yeah.
think that, missing doses you could get away with it. So interesting. I'm curious about like the mechanism. Why is it so
Yeah.
much more forgiving where you really start dropping off with the non-dolutegravir based regimens? All right, jumping into the article, dexamethasone in adults with viral meningitis, an observational cohort study published in CMI. This data comes from an observational cohort study of adults hospitalized for viral meningitis, both with and without a microbiologically confirmed diagnosis in Denmark between 2015 and 2020. I think I like this because it's in Denmark, but then they're going to use the Glasgow outcome scale, right? So you got some of my favorite places here. But dose-dependent associations between dexamethasone and an unfavorable outcome using the Glasgow outcome scale at 30 days after discharge were assessed. Of 1,025 included patients, 64% did not receive dexamethasone, 11% received 1 to 2 doses, 13% received 3 to 4 doses, 12% received 5 or more doses. Among patients treated with dexamethasone, the median number of doses was higher for those with an identified pathogen than for those with a microbiologically confirmed viral etiology. Using no doses of dexamethasone as referenced, right? It's going to be our reference. The weighted odds ratio for an unfavorable outcome was 0.55 for 1 to 2 doses, 1.13 for 3 to 4, 1.43 for 5 or more doses. In the subgroup of enteroviral meningitis, the odds ratio was 3 for greater than 5 doses, but decreased to 2.35 when the reference group was restricted to patients treated with antibiotics for suspected bacterial meningitis. So really kind of interesting. Like I sort of struggle with using dexamethasone and meningitis when you don't necessarily have a diagnosis, but the authors concluded that this study showed no dose-dependent association between dexamethasone and an unfavorable outcome in patients with viral meningitis. In enteroviral meningitis, greater than 5 or more doses was associated with an increased risk of an unfavorable outcome. So it sort of seemed like that one dose up front was kind of reasonable, but get a little concerning when you start dropping 5 or more doses.
Yeah. This next one, I think most people have probably started to hear about this, and I think it's been in some of the like popular news type outlets, but in the CDC MMWR early release, there's a report on Oropouche virus disease among U.S. travelers, U.S. 2024. If I'm mispronouncing it, someone can
You can just
please
call
email
it
me
sloth
directly.
fever,
Yeah,
right?
sloth. I was feeling people were focusing more on the sloth. I did include a picture. There was a Lancet ID paper too called Oropouche fever, the mysterious threat. And so I included this little picture of a sloth. But if you are a loyal Puzzcast listener, you might remember that I mentioned a narrative review of this previously. It must have been a little while back because at the time I hadn't really learned anything about this arbovirus. So that gave me a little bit of background. There have now been a total of 21 virus cases among US travelers returning from Cuba. That was in as of like mid-August, I think. Most had self-limited illness. At least 3 had some sort of recurrent symptom. So just for refresher, this virus is a orthobunya virus. It's endemic in the Amazon region, and previously, and most of these papers that we've mentioned focused on it as a cause of human disease in several countries in South and Central America and the Caribbean. And so the clinical presentation is quite similar to other arboviruses like dengue and Zika and chikungunya. There's a incubation period of somewhere in the window of 3 to 10 days, and patients have those like fevers, chills, headache. They just have lots of myalgias. And something that is interesting that up to 70% of patients have some sort of recurrent symptoms after their initial recovery. And so as Daniel mentioned, the people are linking it with sloths because it has a reservoir in sloths, non-human primates, and some birds, and it's transmitted by midges and mosquitoes. And I think it's Aedes mosquitoes. I should have written it down, but yeah, just something to be thinking about in your patients, particularly if they've been in areas where it's more prevalent.
Yeah, I think the poor sloths. Most of the time, it's not
They're
the
just
poor
getting
sloths.
better.
But they are so cute. When we go to in Panama, a lot of times you'll see the sloths. You just have to like really look because they move so slowly. You don't catch that movement.
Yeah.
But yeah, sometimes even on like the base, there have been a time with like sloths just like hanging out there at the base in Panama. So I like sloths. All right. The article High Rates of Non-Susceptibility to Common Oral Antibiotics in Streptococcus pneumoniae, Clinical Isolates from the United States, 2019 through 2021, was published in Open Forum Infectious Disease. And, this stuff's really critical. I mean, I think every time someone prescribes an antibiotic, ideally there's like up comes your antibiogram and you know what's going on. I have to say I was shocked in Taiwan at the degree of drug resistance going on there. So with that being said, it's all here in the abstract. Streptococcus pneumoniae isolates from the USA. They have an N of 1,038, 2019 to 2021. And here's susceptibility to omadacycline, Cycline, 99.8%, levofloxacin, 99.7%, ceftriaxone, 98.1%, so it's pretty good. Whereas doxycycline, 80%, oral penicillin, 63.5%, cefpodoxime, 76.8%. Quarter of the time, you're not covered it. And azithromycin, why bother? 54.4%. So they say this data suggests that ometacycline, right? That's a prescription that, I never use. A tetracycline with the name brand of Nuzyra is an important option for treatment of community-acquired bacterial pneumonia. Except, Sarah, what is this ometacycline? Well, according to the Mayo Clinic, ometacycline is used, I'm not sure by whom, to treat community-acquired bacterial pneumonia and acute bacterial skin and skin structure infections. I have never used this medicine, and apparently the recommendation is for treatment of CAP, 300 milligrams twice daily on day 1, and then daily days 2 to 5. Comes in these 150 milligram tablets that cost $315.79 each. So if I do the math correctly, that's about $2,000 for a 5-day treatment course.
I've very rarely used that, and I definitely have not reached for it for just as a first step. I don't feel like it's usually that easy to get, but separate issue.
$2,000, that's
Yeah.
But it is, just think of, we're losing cefpodoxime. We have, just about lost azithromycin. Doxy, we're getting 80%. We're like barely getting a B on that one. So 20% of the time it's not working. And I'm not a huge fan of us continuing to use so much fluoroquinolone here. So. All right, let's move into bacterial. Be sure to listen to TWIM. We're actually going to record a TWIP later today with a paper from Michael Schmidt. So sort of a crossover. We're not going to let him on, but we will let his paper on. So here in New York, we recently got the advisory. New York State Department of Health directs providers to discontinue use of ciprofloxacin to prevent meningococcal disease due to increasing antimicrobial resistance. So the New York State Department of Health issued an advisory to healthcare providers, directing them to discontinue the use of the antibiotic ciprofloxacin to prevent disease in individuals who have had contact with patients diagnosed with or suspected to have had invasive meningococcal disease due to, as we've been talking about, an increase of antimicrobial resistance. Instead, they should use rifampin or ceftriaxone. So at this point, 20% of the isolates collected from invasive meningococcal disease in New York City, outside of New York City in 2023, were resistant to Cipro, and 17% in New York City. So 20% overall, 17%, about the same in New York City. The CDC recommends discontinuing Cipro, PEP, when at least 2 patients and 20% in a local catchment area have resistant strains. So kind of past that.
My next one is, I realize I have multiple. This one's from MMWR. Notes from the field.
MMWR.
Yeah,
Sarah.
I mean, there's always lots of good things in there. So, tularemia associated with harbor seal necropsy, Kitsap County, Washington, October 2023. This was a case of tularemia that occurred in a wildlife volunteer after exposure to a deceased infected harbor seal. It sounds like she was working as a wildlife biologist for a nonprofit and nicked her finger with a scalpel while doing the necropsy on the harbor seal. So although she was wearing PPE, it sounds like the cut went through the glove. And I think she must have done okay initially, but then had inflammation and pain at that cut site, followed later by fever and lymph node swelling and cough and congestion. But she is now recovered after a treatment course with doxycycline. But this is the first known report of tularemia acquired through contact with a marine mammal. And this is the first detection of Francisella tularensis in said marine animal, because we usually study and learn about how its reservoir is lagomorphs, so rabbits and hares and rodents. So if you need a different story other than the Martha's Vineyard grass cutting rabbit story, this is your next. example that you can bring up this paper and think about it in more unusual things. But first case ever for a marine animal, which is pretty interesting.
Yeah, that's always the stem, right? The person was like cutting their lawn in Martha's Vineyard and ran over a
Yeah.
rabbit and wasn't wearing an N95,
Yep.
because most
And
of us
I'm pretty
don't.
sure one of the New England Journal clinical cases recently might have been tularemia. I meant to go back and try to find it, but if I do, I'll add it and they can put it in the show notes.
Yeah, I remember a case up in Alaska, and the guy was skinning a rabbit. It was classic. It was like classic stem. Like, of course, you were skinning a rabbit. All right. So, US FDA approves first at home syphilis test. I mean, we're recording on a Friday, so I've got my clap bow tie, right? It's actually Transmitted Infection Day. I'm just celebrating. The US FDA granted marketing authorization to the first at home over the counter test to detect syphilis antibodies in human blood in a move that could help boost screening rates for sexually transmitted disease. Sounds like a commercial, right? Developed by privately held Now Diagnostics, this antibody test is going to give you a result in about 15 minutes. However, the regulators added that the tests really should be confirmed. So, if you use this, you get a positive test, you should go on to, sort of think of it as a screening test and then go on to see your doc and get this confirmed.
All right. And then you talked about strep pneumo not just a couple articles ago.
Yeah, the fact that none of our antibiotics work anymore.
Well, I guess I'll have like a different message. So this is from CID, clinical impact of pleural fluid streptococcus pneumoniae PCR testing in children with complicated pneumonia. This was a single center pre-post quasi-experimental cohort study that looked at implementation of pleural fluid strep pneumo PCR assay in children with complicated CAP who required pleural effusion or empyema drainage. And they found that more pathogens were detected in the post group, driven mostly by strep pneumo PCR. So that was 73% versus 39%. Fewer patients ended up on MRSA therapy, that being a difference of 73 versus 46%. And then just generally, more patients got to what's considered sort of optimal therapy in a faster time frame. So that difference was 84 versus 53% getting to that quote optimal therapy, and the shortened the median time to this antibiotic regimen from it was 4.9 versus 10 days. So a pretty significant difference. And so the, implementation of this led to more microdiagnoses, better optimization of antibiotics downstream. And I think for everyone who is a pediatrician, you have had these patients who come into the hospital, they kind of have a pretty long admission. And a lot of times we don't have a diagnostic that comes back. And even though strep pneumo is the leading cause of complicated CAP, having that microdiagnosis makes a huge difference. And the authors even pointed this out, that despite having well-established treatment guidelines, an active antimicrobial stewardship team at their institution, and I think this is similar in many other hospitals, many clinicians are unlikely to narrow to something like ampicillin, even if it's in the guidelines, without a pathogen identified when they have that diagnostic uncertainty. So they end up on these regimens of much broader coverage because often they looked fairly sick when they came in. The other thing that I thought was kind of interesting, they reported in their data how many of the patients had a pathogen detected from Carius or plasma metagenomic next-gen sequencing. And the Carius test predicted pathogens at a rate of 80%. So just something like an interesting nugget. I've often taught that complicated pneumonia or these sort of not necessarily strep pneumo cases that I suspect, but more unusual, maybe cavitary pneumonias can be a place where Carius can be valuable. But obviously, if you can get pleural fluid and send that and have directed tests, that's like the best case scenario. But just a cool little piece of additional information. So kind of the opposite message of not reaching for a metacycline. Like we can hopefully get more patients. We want to get them on something like AMP if we can. because it's probably strep pneumo.
Yeah, it's interesting when you concern like about the resistance rates. Like, you think AMP seems great, but I think we just, what was it, like 50% now is, was it 63.5% is sensitive to our ampicillin.
Yeah.
Yeah, not so great. But cefpodoxime is not much different, 76.8, right? So
Yeah. I think
I
it's
want
hard
to not
because,
only know the pathogen, but I want sensitivity too.
yeah. And I think like many of these complicated pneumonias, they have persistent fevers. And that's another reason
Mhm.
people feel hesitant to narrow
Yeah.
with a lack of a microdiagnosis, which I think we know that often they're just having fevers because it is a complicated infection, and we know that that happens. But
Yeah.
um, sometimes it's hard to compel, to reason with other people that that could be an expected part of their course.
Yeah. Part of the natural history.
Hmm. Hmm.
All right. The article, The Role of the Gut, Urine, and Vaginal Microbiome on the Pathogenesis of Urinary Tract Infection in Women in Consideration of Microbiome Therapeutics, was published in Open Forum Infectious Disease. So I think our listeners probably know, but the gut, urine, and vaginal microbiomes actually play significant roles in the pathogenesis of recurrent urinary tract infections. And analysis of these microbiota has shown distinct associations with UTIs. And encouraging data indicate that recurrent UTIs may actually be responsive to microbiome treatments, such as fecal microbiome transplantation, expanding potential treatments beyond just antibiotics, hydration, and these ineffective behavioral interventions. So, for our background, in 2008, the Human Microbiome Project was launched to understand the contribution of microbial composition to human health and disease. But they did not include the urinary system because, as I learned in medical school, the urinary system is sterile. Well, that's not true. So, unfortunately, the development, or fortunately, I think I'll say fortunately, the development of improved culturing methods revealed that, yes, the urinary system harbors a distinct microbiome. So we are learning. This was, they said 50% of what we teach you is not true. Well, that was part of that 50%. Most uropathogens are of GI origin. However, data also demonstrate an important role of the vaginal and urinary microbiome. And so they've got this large study of 435 cultured urine specimens. Find approximately 2/3 of the bacteria were shared with gut, 1/3 with vaginal repertoire. So this is a review and even covers the important role of this urine virome. There's even a urine virome. So the authors conclude by writing, historically, antibiotics were the sole treatment for managing urinary tract infections. However, the emergence of multi-drug resistant organisms has prompted the exploration of more innovative approaches, such as vaginal probiotics. We talked about a paper on that a few episodes back, and fecal microbiota transplant. These treatments have shown promising results and hopefully will offer effective alternatives in combating urinary tract infections, especially in cases where traditional antibiotic therapies may be less effective due to resistance issues. All right, and that's going to move us into fungal. I still haven't watched this sneak peek, so I'm gonna watch the
Gotta
sneak
do
peek of The Last of Us season, like right after this episode, Sarah. The article, 2 dose levels of once weekly phosphoruvconazole. Yeah, how do you pronounce that?
I don't know that I have an
Okay.
attempt.
Okay, phosphorubicconazole
Phosphorubicconazole.
versus daily intraconazole in combination with surgery in patients with mycetoma in Sudan. A randomized double-blind phase 2 proof of concept superiority trial was published in the Lancet Infectious Disease. So mycetoma is an implantation mycosis characterized by large subcutaneous mass in the extremities, commonly caused by the fungus Modarella mycetomatus. And I've actually seen a number of these, Madura foot infections, not only over there in India, not far from Madura, but actually even here in the US. A poor lad I had who just kept actually chopping parts of his foot off until finally he saw me and we treated him with an oral antifungal. Anyway, here they compared the efficacy of 2 doses of ravuconazole, a synthetic antifungal designed for use in mycosis and repurposed for mycetoma with standard of care itraconazole, both in combination with surgery. Basically, all the same, no superiority. However, phosrabuconazole presented no new safety signals, lower pill burden, reduced risk of drug-drug interactions. But then it's relatively relatively so compared with the, as they say, relatively expensive and inaccessible itraconazole, suggests that this might be a potential effective treatment, warrants further research because this might have a shorter duration and higher cure rate without the need for surgery. All right, and I'm going to move us into parasitic. I got a few cases here, so be sure to listen to This Week in Parasitism, both our mystery case episodes and our special guest and paper reviews. But we have the article, Usefulness of Real-Time PCR for Urogenital Schistosomiasis Diagnosis in Preschool Children in a High Prevalence Area in Angola, published in PLOS NTDs. I think really the important here is that, when you think of urogenital schistosomiasis, this might not have the same parasite burden of some other infections. So here you're looking at using a more sensitive approach so you don't miss the diagnosis. And in this real-time PCR microscopy were used to diagnose urogenital schistosomiasis in preschool children in Angola. Urinary tract lesions were assessed by ultrasound. Of the samples tested, 64.95% were positive by real-time PCR, compared with only 37% microscopy. So much higher sensitivity. So I just want to share that. We also have the article, Helminth infection-driven GI hypermotility is independent of eosinophils and mediated by alterations in smooth muscle instead of enteric neurons, published in PLOS Pathogens. So I have to say, at first glance, this might appear a little too basic science, right? But there's really an interesting finding here that I think impacts our paradigm of diarrhea. So we read that intestinal Helminth infection triggers a type 2 immune response that promotes a weep and sweep response characterized by increased mucus secretion and intestinal hypermotility, which function to dislodge the worm from its intestinal habit. Recent studies have discovered that several other pathogens cause intestinal dysmobility through major alterations to the immune and enteric nervous system and their interactions within the GI tract. So despite the critical role of the ENS in regulating typical intestinal function, very little alteration to ENS structure or function was observed following this nematode infection. Instead, using this Nipostrongyloides brasiliensis as a model of murine hookworm infection, infected animals displayed dramatically increased smooth muscle thickness and contractile strength. So it turns out that in contrast to other intestinal pathogens, myogenic rather than neurogenic alterations drive small intestinal hypermotility and pathogen expulsion following intestinal Helminth infection. I know. I found that fascinating. So, all right. Now, this next case report, die-off of reaction of Demodex mites after treating demodicosis with oral ivermectin, a case report published in the Journal of the American Academy of Dermatopathology. So what is this demodicosis? So you basically have an abnormal increase in these Demodex mites, which are these ectoparasites found in human pilosebaceous units. And then you end up with all these skin symptoms. And I really wanted to share this paper because, to be honest, how many of our listeners are aware to even consider this diagnosis, right? People come in, I got this rash, a lot of times you're crazy, it's not a parasite, stop bothering me, go see someone else, bother them, right? So I just want a sort of awareness that people are even considering this, and so they can even be aware of how one might approach this. So the standardized skin surface biopsy, SSSB, is this method utilized to detect the Demodex mites. So you place a 1 centimeter square marked slide coated with this actual special glue on the affected cheek area for a minute, and then you gently remove it. you do some immersion oil, and you actually look under the scope, and you're going to count how many Demodex mites you see, in this area. And basically, you might see some, but it's really a question about doing counting here. So here in this case report, they've got this 51-year-old male. He's got this facial redness, this dry, scaly, hyperpigmented patches. He's got stinging sensation on the face. They've got these great photos of sort of before and after pictures. And so they start off, and initially there are 74 mites per square centimeter, 82 mites on the other cheek. So they go ahead, they diagnose them. Imagine that, demodicosis. They actually make the diagnosis. They treat him with some ivermectin, 2 doses, a week apart. He actually gets worse. I want to point out that's what you expect, right? So his cheeks, they look redder, slightly more swollen. He also says he's now got increased dryness and stinging. The rash on the eyebrows is worsening, starting to peel. So what do? They keep treating him. He keeps taking the oral ivermectin, an additional 4 weeks. Then he ends up with another 2 weeks, basically cut to the chase. He eventually gets better. And what is going on here? And I think it's sort of important to know that these individuals often require prolonged treatment, probably need to treat them for 2 to 4 life cycles, because initially what you get is this die-off reaction. And as the mite dies, its contents and the numerous bacteria it carries spread out onto the skin. And actually you initially get a worse inflammatory response, and then they actually get better. So sort of important to understand the treatment and the expected response.
Yeah. Well, I didn't know about that diagnosis. Look at all the things I'm learning.
So increasing awareness for our listeners.
Yeah.
All right. So in miscellaneous, we have the article. I think this is about my last article, and it's all Sara.
Sorry, I made you have a stretch there.
No, that's good. The prevalence of, I'm on like this drug resistant, the antimicrobial resistant apocalypse is in front of us, right? So the article, prevalence of carbapenem resistant gram-negative bacteria among neonates suspected for sepsis in Africa, a systematic review and meta-analysis published in BMC Infectious Disease. So here we read, you ready for this? The pooled prevalence of carbapenem resistance in Africa was 30.34%. The pooled estimate of gram-negative bacteria resistant to imipenem and meropenem, right? This is neonate sepsis in Africa, 35.57% and 34.35% respectively. Acineta baumannii and Pseudomonas species had really these incredibly high prevalence, 46%, 43%. Not great. Really, I always thought of, a lot of these places, hey, that's where antibiotics still work. Well, not so much anymore.
Yeah. And I will wrap us up with 2 that I put here in the miscellaneous because they didn't quite fit anywhere. The first one is just a quick overview from CID, a new era of targeted clinical guidelines, launching the IDSA guideline supplement. And the article is just pointing to the sort of inauguration of this new publishing model that they're going to use for IDSA clinical practice guidelines. And instead of having those sort of larger comprehensive guideline documents, the goal now is to sort of overhaul that and put out smaller manuscripts that often are addressing only an individual clinical question. So like single PICO type questions as a manuscript. And so the IDSA website then would serve as this like primary platform for you to access it, with eventually a CID supplement that would follow. And they put like a little diagram here, but basically instead of waiting for these like hugely long time periods for people to gather and summarize all the PICO questions, putting it out in the journal, and then later getting it on the website, it's sort of flipping it so that you will have quick access to these online and sort of smaller chunks. And I think that'll be really, really nice. So looking forward to that. And the last thing that I pulled was from OFID, defining the landscape of educational experiences in transplant infectious diseases, a national survey of infectious diseases fellows in the U.S. I'm like totally going to announce this is my bias. This is like my jam. This is what I love. But this is results for the fellows who may have filled this out, the AST, American Society of Transplantation ID Community of Practice. And they sent this out to adult and pediatric fellows in the US who may have either been in their general ID fellowship or perhaps they were in a dedicated transplant ID training program. And I'm going to summarize this in only a couple of things, but basically over half of fellows described not having some sort of formal curriculum or content related to what we consider foundational topics in transplant medicine. And even though most people did say that they had inpatient transplant ID experience, most had less than 12 weeks annually. And there was kind of a variety of not just clinical exposures, but maybe other administrative aspects of being in transplant medicine that they may or may not have been exposed to, like listing meetings and so on. So, I mean, the take home here is that both these didactic experiences and then the clinical exposures are quite variable, whether or not you're a general ID fellow or in sort of a TID track in fellowship. And that could be limitations in scope in both inpatient or outpatient or other aspects of transplant medicine. So there's some gaps here that we can work on. And I think a big part of that is having curricula available for folks and other educational resources. So I thought this was really nice if people want to check it out and kind of think about it, how it compares to maybe your experience. All right. And that brings us to the end of Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can grab the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or with your favorite podcatcher. We'd love to get your questions, comments, paper suggestions. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV. www.microbe.tv/contribute or Parasites Without Borders. ParasitesWithoutBorders.com. Click on the donate button.
I'm Sara Dong. You can find me at swindong at Febrile Podcast or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at ParasitesWithoutBorders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.